This week we have Dr. Anthony Gabriel. Anthony is one of the most seasoned and experienced people in this field in terms of both building businesses in healthcare and understanding where the field is going in terms of how this all intersects with longevity. He was one of the leaders at one of the largest, well, before that, he worked at DaVita and was, I think, chief informatics officer.
I was the chief information officer for about 5 years before leaving. Spent a total of about 15 years there in operations, revenue cycle
Mhm.
management, and eventually before leaving there in 2012 to start Radiology Partners.
Which is now one of the largest radiology groups in the country and obviously has tremendous visibility into the practice of medicine, really, from that vantage point. Imaging is such a big part of it. And he's now started a business that intersects with longevity by providing comprehensive imaging as a cornerstone. And today he's going to talk to us about one of the most high potential applications of that, which is cardiovascular screening. I will turn it over to him to add to what I just said. We can also dive right into your presentation. But I think I would just say why Anthony's perspective is important is because of of this tremendous industry experience, like working at, Fortune 10 or 15 company at the highest level and having built a radiology business to be one of the largest groups in the country. He has a really valuable perspective about how imaging can work for people generally. And I think he's excited about the potential to advance into this new era of longevity medicine using imaging in a very specific way. Anthony, I'll turn it over to you. Thank you so much for joining.
Thanks, Anant, and thank you everybody for joining. Really excited to be able to talk to you about this today. I gave a lot of my background, and yes, I have spent about the last 12 years. I was one of the two founders of Radiology Partners, which we have about 3,500 radiologists and serve clients in all 50 states right now. And so got really comfortable with managing radiology, radiologists. We operate over about 120 imaging centers or so as well. So some of the technical aspects of radiology as well. And left that business about a year and a half ago, and have been interested in prevention for the last 6 or 7 years. And what got me excited about it as a physician, I'm an internist by background. I'm not a radiologist. I practiced full time for about 10 years. And what got me really excited about it was that the science around prevention is now getting to the same level as the science around treatment has been for the last 50 or 60 years. We have been investing a lot in rigorous science around developing great treatments, and we're very good at it here in the US and around the world. But now the science around prevention is starting to catch up with that. And that's what's so exciting to me. It's really for all the diseases of aging, which, in addition to becoming much more common as people get older, also have multi-decade disease paths that are invisible to the patient because the patient has no symptoms, yet with today's advanced imaging techniques are visible to the scanner. And that's really what the business I'm doing is all about, is combining the practice of longevity medicine, of extending lifespan, of preventing the diseases of aging with a medical practice, with an imaging center that is dedicated to serving that clinical need. Because the existing imaging centers that are out there, including the ones that I used to operate, don't do that very well at all. If anybody's tried to send a patient to get a coronary CT angiogram at a traditional imaging center, you know a little bit about what I'm talking about, because patients get so wrapped up in whether or not what's the pre-auth, how much is it going to cost, why are you getting this, that they just get frustrated and give up eventually. And so we're building out an imaging center that will serve our practice and plan on then replicating that model across major cities across the United States. That business is not open and running yet, although we're swinging hammers on a location right now to get it open. What I want to talk to you about is clinically one aspect of that, and what I think is probably the most important one, which is around cardiovascular care, in particular coronary disease. The date on this presentation is November 15th. I gave this talk a little less than 3 weeks ago at the Southeast Society for Coronary Imaging meeting, and gave it to about 150 cardiologists, radiologists, and primary care doctors that were in Florida for this meeting, talking to them about this very same topic. You're going to see the exact same slides that they saw. And there is a subset of imagers in that group that very much believe in this, but it's definitely something that we're trying to create a little bit more energy and momentum around. And hopefully by the end of this, you understand why. Anant, is the best way for us to do this to go through the talk and then take questions at the end?
Yeah, let's do that. People can feel free to drop questions in the chat. and we can do it that way.
So, starting off, this is really the underlying premise of why this is so important right now. The way most people today are treating coronary disease or treating people who potentially have coronary disease is by using a lot of the risk models that you guys are all probably familiar with and have plugged in age, LDL, and smoking status into some sort of risk calculator, which gives you a score as to what the risk level is for that patient. And it tells you what the probability is as to whether that person has disease. And then there's some recommendations with regards to how we treat them, in particular around what we manage their lipid levels to. And we manage their lipid levels to those numbers. And yet, despite all that, people are still dying from this disease on a very frequent basis. In fact, if you look here, I think this is probably familiar to most of you. Heart disease is still the number one killer in the US. It's the number one killer in the developed world. And 50% of the events that occur, the MIs that occur, happen in people that are completely unaware that they had coronary disease and were classified as low or moderate risk. So that question at the bottom is, in today's world, how is it possible that the first sign of disease is a heart attack? The very end of the disease progression. We all know that that person who shows up in the ER with an MI has had disease for years, if not decades, prior to them showing up in the hospital. And yet, this is still how we manage this disease in the US. If this is a report card, we as a healthcare system are doing very poorly. We are not doing a good job of this at all, and we can do a lot better. So think about this as two paradigms in terms of how we manage the disease. And I'm not talking about managing disease once somebody has angina or an infarct. I'm talking about how we manage atherosclerotic disease as it develops and gets up to that point. What we currently do is over on the left. We put a bunch of inputs into a risk calculator. We get a probability output. We know if somebody's higher or lower risk, but we don't know for sure if they have it. And then we put them on therapy and we're managing their cholesterol, but we can't really tell them yes or no, you have coronary disease. We can't tell them yes or no, you're going to have an MI next week or not. And people take their statins or maybe do some lifestyle intervention. And then we wait and see what happens. We could be scanning people. We can see this disease very well with current scanners. We could be scanning these folks and seeing whether or not they have disease. We could be measuring how much disease that they have, which is also very possible with the technology today. And then we could target therapy because there's a lot more to prevent this disease available today than just statins. And we're not using most of them because we don't know who to use them on. But we could be targeting that therapy in a much more precise way than we are today. So the framework of the talk is really first talking a little bit about the problems with our current approach, the challenges that population-based medicine introduces when we introduce this disease. The second, we're going to get into looking instead of guessing, and that's where I'll get into a bit more about the technology that exists today combined with artificial intelligence, which enables us to do things that we weren't able to do 10 years ago. And then third, targeted therapy. Although we're going to get in, and I will spend a few minutes talking about cool new scanners that are very expensive and do amazing things, this is not a talk about a cool new scanner. The talk is about a care model shift. It's about changing the way we think about assessing where these people are with their disease and changing how we treat these patients. I really believe at this point that we can reduce the number of patients that die from this disease if we were able to get this to happen across the country by a factor of 10, literally reduce this by 10 times. I think the tools available today are absolutely available to stop the progression of plaque in most patients, not 100%, but in most patients. So why now? Why aren't we doing this yet? What's changed? What makes this possible today? It's really the intersect of three different things that have enabled all this to occur. First of all, the scanners. These are not the scanners. If you trained a while ago like me, these are not the scanners that you trained with. The scanners today, especially the ones focused on doing cardiac and coronary applications in particular, are very different than the old ones. And most imaging centers, in particular outpatient imaging centers, don't buy these scanners because they're very expensive. And they really serve no extra benefit if you're scanning abdomen, pelvis, chest, neck, spine, brain. They're really of no use for that. But what they are of great use for is getting really good pictures of the heart and also making this applicable to being able to do this in a screening population from a radiation perspective. We'll talk more about the scanners in a sec, but they're fast, low radiation, and great image quality for cardiac scanning. The second, AI transformation. And in radiology, I think many people realize that radiology has been one of the biggest areas of utilization, kind of the front runner when it comes to using AI in medicine. Most of that work has been around, you've probably read articles about how some AI product can detect, pick a lesion, pulmonary nodules, breast cancer, what have you, better than a radiologist can. And although that may be true to some small degree, where I think that technology is going to be even more relevant is doing things that humans really can't do. It's not that cardiologists can't see the plaque, they absolutely can, but they can't go through every single slice of each coronary artery and measure the amount of plaque without spending 15 hours doing it to be able to quantify down to the cubic millimeter how much plaque an individual has. And getting that measurement essentially turns this test from an imaging test into a lab test. Previously, you've probably gotten a report from a radiologist that says this person has moderate plaque. If you've ordered a CTA, you get a test back that says this person has moderate plaque. And then if you treat them and you do another one, they still have moderate plaque. And you don't really know, well, is that better moderate plaque or is that worse moderate plaque? Now you get a number that goes from 250 to 220, probably both moderate, but that's an improvement. Now we know our therapy is working. We can use this tool to manage, which we haven't been able to do in the past. And then finally, the therapeutic arsenal, both from a lipid management perspective, as well as managing metabolic disease, which we all know is a significant contributor to atherosclerosis. We have great new tools, tools that in some cases have been around for a little bit and just haven't been used because they're expensive, and in some cases are really new. But we have a lot of arrows in the quiver to attack this disease. We just need to know who to use them on. And this diagnostic enables us to be able to do that. So that's why this is now the time for us to change how we take care of these patients. So, problem with population-based medicine. First of all, these ASCVD risk calculators that are out there right now, lots of issues with them, right? I mean, they're the best tools we have. So I don't want to say that anybody's made a mistake. These things are not wrong by any stretch and have served us well and have improved care and saved a lot of lives. The risk calculators that we've been using are certainly good. It's just that now, with the tools we have available today, we really can't defend continuing to use them. Why is that? Well, they miss in a lot of spots. They underestimate risk in women, especially women transitioning through menopause. They underestimate risk in patients with significant family history. So, those people that have multiple family members that died in their early 50s from myocardial infarction, they're underestimated risk in that population. They can't fully capture the full breadth of the metabolic complexity, and it really comes to be during this. Group people into just you're either metabolically sick or you're not. We all know there's a wide degree of variation, and that variation drives a variation in the amount of inflammation going on with those individuals. They're not capturing that. Finally, they don't capture unmeasured disease pathways. We all know we've all seen patients that have got horrible risk factors and yet have no disease at all. And we've all seen patients that have no risk factors and are very low risk and have severe disease. So clearly, there are some factors going on with the development of atherosclerotic disease that we don't fully understand. And the risk calculators can't account for those people. Half of all the heart attacks in the country occur in people that are classified as low or moderate risk. And so the risk calculators are not, although they have been helpful, they're certainly not sufficient to capture all the patients that have disease. Let's look at some of the things that go into that risk calculator. So obviously the big one, LDL, one of the larger causative factors with regards to atherosclerotic disease. There's probably different people that have different opinions as to what the biggest factor is in terms of contributing to atherosclerotic disease, this versus systemic inflammation, metabolic disease, et cetera. I don't have a strong opinion and don't want to get into that. It doesn't matter to me all that much. And I think you'll see why as I go on. But certainly cholesterol has achieved dominant mind share in the population around what drives coronary disease. So if you talk to lay people out there, for sure, the first thing that comes to mind for them when they say, "Well, what causes heart attacks?" They think about cholesterol. And I've been out to dinner with friends that might eat a big steak and say, "I'm going to call my cardiologist tomorrow because I just had this big steak." And it really kind of drives mind share about what causes this disease. And yet, if you look at this data right here, you can see that 75% of the MIs that happen in the country happen in an individual with an LDL that's meeting target. So 75% of the MIs, we are doing exactly what the guidelines and all these big population studies tell us to do. And yet 75% of those people end up, 75% of the time, when a person has an MI, they passed all the tests with regards to what we recommended, at least as far as what their LDL level is. And so you can see, other numbers as well in terms of the percent that are below 100. The LDL is not the whole answer and is insufficient to tell us who has disease and who does not. Calcium scores are a good test, particularly when the test is positive. They're helpful when we see that somebody has a significant calcium burden because those tell us patients that we need to investigate further. However, having a calcium score of 0 does not necessarily tell us that that patient doesn't have disease. And that's because calcium deposition doesn't happen for years, frequently 10 years after the development of that plaque. If the person happens to be developing plaque relatively quickly, you can move on from developing soft plaque to plaque rupture, leading to a myocardial infarction prior to that calcium ever being deposited or being visible. Soft plaque is completely invisible to a calcium scan. You can see up there that somewhere between 15 and 45% of the patients with a CAC score, a 0 calcium, have atherosclerosis when you look at them on a coronary CT angiogram. So there's a lot of people that get that clean calcium score and say, "Woohoo, I am good." And yet 15 to 45% of them have plaque there. And 15% of major adverse cardiac events occur in patients with a CAC score of 0. Those are patients that moved having that soft plaque develop to soft plaque rupture by the time before they end up depositing calcium. This is particularly common in women, which take longer to deploy calcium into those lesions. So this is more common in women. But as it gets down to a 0 calcium score, although kind of helpful, it does improve your odds. It doesn't make you safe. And a positive calcium score means you have disease. That's why I think it's still a good test because it tells us we need to investigate further, but it doesn't tell us how severe the disease is today. And it certainly is absolutely not something that you can manage to. Because when you're looking at calcium score, you're looking at really the disease that happened years ago at the end stage of it. If we're to initiate therapy, more aggressive therapy in a patient that's got a positive calcium score, being able to manage that by repeating the calcium study in 12 to 24 months, there is 0 data supporting that. So I think there's a few problems with this, albeit it's a nice initial screening tool. I think about it as a way to capture patients into the system because you get this positive score and you can move them on to the next stage. Stress tests, we all know this is really just looking at flow, not disease. Somebody can have a lot of disease and have no flow limitations whatsoever. It really isn't helpful with managing the disease. In fact, half of all heart attacks occur in sites that are not flow limited. So you have these patients that you get and they've got like a 30% stenosis. There's no FFR limitation at all. So they've got no decrease in flow, and yet that's where the MI happens to happen. So severe stenosis causing flow limitations or even causing symptoms is not necessarily we're going to have plaque rupture and myocardial infarction, which kills heart tissue and causes significant disability. So stress tests miss a lot of these people. It really doesn't work. So why haven't we gotten away from all this with all these problems? Well, I mean, I think one big one is around that middle one, which is the misaligned incentives. We're talking about treating a disease. I mentioned this is a multi-decade disease from the time it begins to the time somebody gets to an MI. Financially speaking, part of my background was spending a lot of time in the whole payer insurance world. The person who's going to be financially responsible for the individual by the time they have this disease is almost certainly going to be somebody else. If you're an insurer, you kind of, from a financial perspective, don't care about this at all. You care about the things that are going to happen to your patient in the next 2 or 3 years, because the median time that an individual in the US stays on an individual plan is about 2 years. So that 2 to 3 year time frame is relevant for you. You want to prevent bad things happening in that 2 to 3 year time frame. Yeah, that's not something we're really interested in. Obviously, none of the insurers say this out loud, but this is absolutely the way they're thinking about it. Part of it too is this technology is new, so a lot of people are unaware of the tech. And part of it's certainly about like this has become a mental model for many of us in terms of how we take care of heart disease, and we just get used to it. So part of it's that as well. So there's a bunch of factors that come into it. So what's different? How are we going to get people to change? What's made all this change? Well, I think the first thing is like the scanners. Not you have in the chat here about we got to get to the thing about radiation. Well, like let's talk about that. This is not the scanner you had when you were a resident. The scanners when we were doing CTA before, big differences. That 10 to 15 millisieverts of radiation. Today, 1 to 2. Typically we can get a normal sized patient done at about 1.5 millisieverts of radiation. That's about 3 months of background, the equivalent of about 3 mammograms. And we're not asking people to do these every year. The speed is way faster. The scanners today, the wide detector, we literally scan an entire heart in a single revolution around the gantry that occurs in less than a quarter of a second, meaning we capture the entire heart, one revolution in between beats. That technology in the scanner has enabled this to be a completely different test than when we first started doing CTA. Very, very different thing. For the patient experience, very comfortable. There is contrast. We have not gotten away from that. But again, the scanner is a sub-second scan. Once the patient is positioned in the scanner, they hear a whoosh and the scan is over. There is a very short breath hold. There's very little prep required. This is a really easy test for most patients. Radiation dose is probably the objection I hear about the most. Again, modern CTA, 1.5 millisieverts of radiation, might get a little bigger on a larger patient, about 3 tomos. And that's certainly something that nobody's really screaming about doing. I think with the way these new scanners work, radiation is really not an issue, especially with the frequency we're talking about delivering these scans to people. Image quality, because of the fact that they're so fast and we're able to capture the whole heart so quickly, we've pretty much eliminated motion artifact. Additionally, because we're doing it in a single revolution, we are no longer having to stitch images together, so we don't have stitching artifact anymore either. So it creates a much, much higher resolution scan. So that's a lot better. The biggest and most important thing, really around reproducibility around the measurement of plaque as a result of AI. To me, this is huge. So there's multiple companies out there. I saw somebody ask about Clearly in the chat. I just came back from RSNA, the big radiology meeting, and had dinner with their leadership team one of the nights. They've become like the Kleenex of AI plaque quantification. They're the name that everybody thinks about, but there's actually 3 other companies that do this. Clearly has been doing it the longest and does it very well, but other companies might be one that's doing something a little bit new that might even be better. I think the most important thing here is when you look at the report, you'll see one in just a slide or two. The AI has enabled this to go from an imaging test to a lab test. So we're no longer relying on these subjective descriptions that come from the radiologist about what disease is. We're looking at very objective plaque quantification, not just of total plaque, but total plaque, calcified plaque, soft plaque, and ultra low density plaque. So we're able to characterize all the different types and quantify each different type. The AI also calculates how much flow limitation there is, and so we know who we need to send for revascularization, or at least a revascularization eval, versus who we should just treat medically. And so this has really changed the way we manage this disease. You can see this is part of a report, and you can see what it's giving you: total plaque volume, low density non-calcified volume, total non-dense calcified volume, and total calcified volume. So you get each characteristic, each type of plaque. And what I've seen happen with individuals is not so much that if you're doing a good job, you get their total plaque volume go down. A lot of times you just see that total plaque volume stay flat. But what you see happen is that calcified plaque volume goes up as a percentage of the total volume, and the uncalcified plaque goes down. And what that means is the person's not forming new plaque. They're just having their old soft plaque calcify over, and that we all know that calcified plaque doesn't rupture. And so by doing that, if you can arrest further plaque progression, you've basically prevented them from getting an insult. And it's not about just doing this once. I think about this test as sort of the new ApoB, like measuring atherogenic particles within the bloodstream. If anybody watches football, I think about that as how my quarterback's doing. Now, if my quarterback's playing really well, meaning I have a very low ApoB, that probably means my team's more likely to be winning. But we all know you can have one really good player and the team might still lose. What this is showing me here, this is a score of the game. Because what I really want to see is I want to see plaque go down. If plaque's not going down, I've got to intensify therapies to get plaque to start going down, or at least stabilize. That might mean if the ApoB is high, I might aggressively attack lipids. I might be attacking inflammation. I might be attacking metabolic disease and managing their blood sugar better. I might be using GLP-1s and trying to help them reduce visceral fat or paracoronary fat. I don't know which, because I need additional diagnostics to know which lever is going to be the most effective, but I need to watch this plaque go down if not this patient's at risk. And so let's get into what we want to do in order to do that. It's great that we have this amazing diagnostic now, but if there were no tools to treat it, well, it's kind of just academic, right? But let's talk about what the tools are that we have to treat. So everybody here's used statins before on their patients. It'd be shocking to me if nobody on the call wasn't on a statin, just given the prevalence of use of that drug. Lots of statin use. I'm not going to go over how they work, which one's best. That's really tier one therapy. It's cheap, it works well, it's got a pretty good side effect profile. Some people can't take it, but decent class of drugs for managing this disease, at least for lowering lipids. Tier two, Zetia, works really nicely on some people, not on others. It depends on whether they're a big cholesterol absorber or not. There's some lab testing you can do to help predict who's going to benefit. What I typically do is try it and check, and if it works, great. If it doesn't work, I take them off. Other drugs, bempedoic acid and PCSK9s are also available. So four really good classes of drugs to treat total atherogenic particle burden to be able to get that ApoB down. Let's talk about this one in particular because this one irks me a lot. PCSK9 inhibitors. Really hard to argue. This is the best tool in the toolbox for lowering lipids. Yeah, if you've used this on your patients, you've probably seen dramatic reductions in LDL and ApoB. The side effect profile is fantastic. There are virtually none. It's an injection with an auto injector that you either take every 2 weeks or every 6 months. So not hard to take. Really, only negative about it is it's expensive. I think last I checked, it's still around $450, $500 a month. And that's why so many people aren't on it. In fact, over 90% of the people who come into an ER with an MI are not on this drug. So I just got done explaining this is the best tool in the toolbox for lowering lipids. We all know lipids are one of the causative factors of myocardial infarction and atherosclerotic disease. How is it that we allow over 90% of the people that have an MI to get all the way to MI and not put them on our best drug? It's mind-blowing to me. And so what the diagnostics enable us to do is see those people that need to be on this drug, this expensive drug, or this class of drugs. And it allows us to manage our therapy precisely to the patients that need it. Just a little personal story. I have some plaque in my own heart. I can't take statins because of myalgias. When I first tried to get on them, my insurance company refused to pay it. Because I'm a physician and run a big healthcare company, I ended up going and ended up calling the CMO of a insurance company that will remain nameless out in California and listen to that doctor tell me, physician to physician, that they weren't going to pay for the statin until I had my MI. And then when I had my MI, I could call them back and they would pay for it. I just hung up the phone. I was like so pissed off. Like you can't, like, it was just brutal. I'm taking the drug, and since then I've gotten it paid for, but it just tells you a little bit about how like the thinking around this is just so backwards right now. It's starting to change, but it hasn't changed all the way for sure. LP little a, certainly also important, another lever that might be able to be pullable in a year. We've got some new therapies coming out, but also really like we need to think about like the important part here. If we see an elevated LP little a, it means we need to be more aggressive. How much more aggressive do we need to be? If we're only looking at blood markers, we really don't know. And by able to manage these patients with the CTA and plaque quantification, we're able to see just how aggressive we need to be. What we really care about is whether or not they're continuing to develop plaque. This diagnostic allows us to figure out just how important it is. Similarly, lots of new drugs on the metabolic side, at least a couple between GLP-1s and SGLTs. The first one obviously has been here for years, but the SGLT2 inhibitors and GLP-1s, expensive therapy, we know we can better target patients with these therapies. Modulating inflammation, very good data about colchicine and the positive effects in terms of minimizing cardiac events, but comes with a bunch of side effects. The diagnostic that we've got here enables to know like when those side effects are worth it. Because in some patients they are. Somebody that's got severe plaque and we're having trouble getting that plaque to go down, those are patients that'd be good candidates to put on colchicine. Using it on a routine basis, probably not. But if we're at the end of the road, we've got them on multiple other therapies and we're still seeing plaque progression, those are folks where colchicine would be appropriate. And then finally, behavior. A couple of new studies that just came out recently showing a change not just in patient behavior, but remarkably in physician behavior. The ability to visualize plaque quantity and review those images and numbers, showing something beyond just LDL or a risk factor for disease, but showing that individual the exact amount of disease that they have, changes that person's behavior, makes them more likely to comply with therapy, both pharmacotherapy as well as lifestyle intervention. So being able to show that information to the patient, very, very helpful, both for them and gets the doctor more aggressive typically as well. Let's see here. Evidence. So I mentioned this stuff about that, stopping soft plaque will stop disease. To be honest, we do not have an RCT on that yet. There's a couple going on right now and a big registry being built out. The data is coming, but there is so much soft evidence around this right now that I just can't. I don't know how I wrap my head around saying this isn't the right tool to use. I mean, we need to start providing the data into the registry so that we can continue to follow this. It really doesn't make sense for us to wait until the RCTs are done before we start treating patients this way. So how do we implement? First of all, it really has to do with what happens in primary care, what happens in cardiology, and what happens at interpretation. And I use the word interpretation because both cardiologists and radiologists read these studies, so it's not one or the other specialty. For primary care, like when would you do this? Who would you order this on? First of all, anybody at intermediate risk with any kind of discordant markers, family history, really bad metabolic disease, really elevated hsCRP or homocysteine or something that you thought made them at higher risk. Anybody with a positive calcium scan. If they got a positive calcium scan, you know they have plaque, you just don't know how much. It's worth finding out. Anybody that's got persistent symptoms with a normal stress. Strong family history. Like if any, I actually recommend that people get it in their 30s. If your parents, particularly your father, had it in his 50s, you should get imaged in your 30s because that's when we want to start treating you. And also just that kind of last one is just like anybody freaked out about this and wants to get it done. It's a fast, easy, low radiation test. Anybody who wants to get it done, I think it's just fine. You do not need to be a cardiologist to order this test. The wait time to get into a cardiologist is long. And candidly, most of the cardiologists I know don't want to be seeing asymptomatic individuals just to order a coronary CT. You don't need to be a cardiologist to order this test. You don't need to be a cardiologist to understand the results of the test. So I think it's totally appropriate for primary care doctors to be ordering this. Actions after you get the data back. You want that quantitative data. The only time you don't want the quantitative data is if you get the coronary CTA and the interpreter says there's no plaque. If there's no plaque, the computer's just going to agree with them. It's really not worth the expense of even doing that. That's really the only time you don't need the quantitative plaque data. Otherwise, you always want to run the quantitative plaque analysis, which could be clearly HeartFlow, Elucid, Circle, and a few others. There's other companies that do the software. And then you can start to adjust your therapy based on the amount of plaque that you had. You saw some of the recommendations in the earlier Decide registry page about just how aggressive to be depending on how much plaque burden is there, and using that to guide your intensity of therapy versus just what their ApoB is, because we all know there's more to this than just lipid levels. And then third, continuing to use the test. Right now we're doing 18 months, but there are some that are doing faster. I think probably more like slower. So it's like the 18 to 24 month timeline where you repeat this scan after initiating therapy and see if the therapy is working. It's a multi-year, even multi-decade disease. You don't need to be in a big rush, but we're trying to see, okay, we got a plaque level of X. We started the therapy that we think is appropriate. Did the plaque level stabilize or decrease? If it got worse, then I need to intensify therapy. If it gets worse, I've got to do something. Depending on that individual patient, lipid markers, inflammatory markers, et cetera, it's going to tell you what lever you want to pull, but you need to intensify therapy for that person. And Again, as you saw before, we have a lot of therapies for this. From a cardiology perspective, it's really pretty simple. Like it's the same thing as the PCP for the cardiologist, but with one additional thing, and that is, are there people that are going to need revascularization? The people who are doing this and have been doing it for a while tell me that about 2% of the asymptomatic individuals that they scan actually end up with revascular, some sort of revascularization. A smaller percentage, about 10% of that 2%, is ending up with bypass. You will find people that need revascularization as a result of doing this, even in asymptomatic individuals. Obviously, that's when you refer. That's the one additional thing that the cardiologist needs to do as well. Reimbursement barriers. Reimbursement is expanding. The AI for this just got approved for reimbursement by Medicare, so they are paying for plaque quantification in patients that have symptoms or have had a prior event. If you have any kind of symptom, that could be chest pain on exertion, dyspnea on exertion, et cetera, they will pay for that test. So it's improving, but yes, a lot of this is DTC right now, and there's a growing interest in the number of people who want to get it done that way. Is calcium score enough? I think I addressed that. If it's zero, it's helpful. If it's positive, it just to me is an indicator, even more so to get the test done. Radiation risk. The only thing important is to help that patient figure out they're going to somebody with a new scanner. If they're seeing a center doing a coronary CTA on a 2014 scanner, they are getting a lot of radiation. And so you want to make sure that you can talk to your patients about going to get the scan done and ask that imaging center, like, hey, what's the radiation exposure? Because you can do this test in that 1 to 2 millisievert range. Don't get it done someplace that's not appropriate for a screening examination. And then the final thing is, won't this cause all this downstream work, all this downstream cascade of treatment and additional testing, et cetera? Yes, it will cause additional therapy, but additional appropriate therapy. Remember that early slide. This is the number one killer of people in the Western world. And it's because we're not identifying the people who have disease until they have an MI. It's about time that we change that. We can't justify the way we've been doing it. So that's it. Like in my mind, like we don't need a whole nother generation of people finding out about their heart disease in the ER. The tools are here both to see it and to treat it, and we need to change it. Thanks. I'll scan this thing here and see if I caught all the questions. Cost of scan. Let's see. With the AI, all in, I know several places around the country that are doing it for about 2 grand, all in. I also know one place in New York City that's doing it without the AI for $400. And then we'll do the AI on top of it if you want it. If anybody's in New York, I can tell you where that is. They're right in Manhattan. And a really good cardiologist is doing it. I would say one of the guys who's trying to champion this change in mindset. Trying to get it covered. You can try to get it covered. So again, anybody who's got any symptoms, if somebody tells you they're short of breath when they're climbing the stairs, those are symptoms. You can try to get it covered. I can't guarantee what the insurer is going to do, but you can try to get it covered. The cost of the AI read varies. The Medicare reimbursement got approved for $1,000 Medicare reimbursement. As a person who ran over 100 imaging centers, I will tell you that the Medicare reimbursement to get the coronary CTA done is about $380. The Medicare reimbursement for the doctor that interprets the scan is about $42. The Medicare reimbursement for the guy who pushes the button and runs the software is about $1,000. This makes absolutely no sense to me, but it is what these items get paid for by Medicare, which is why you're seeing a hard time getting people to do the actual scan because it's a money loser for an imaging center. It's really hard to make it make sense. Why you're seeing people charge more in the DTC world to get it done, and you're seeing some patient demand. Obviously, the population has to be able to afford it, but there's patients who want to get it done. Right now, there's a limited number of cardiologists and PCPs that are doing this. Everybody's kind of talking to each other and trying to figure out what the right frequency is to repeat it. People want to do it as frequently as possible so they can adjust therapy, but no more frequent than that because we certainly don't want to be repeating the test when we don't even know if we gave the therapy enough time to reduce plaque or see the plaque change. So I think I think people are trying to figure out the answer to that. So 18 months is about, I have seen a couple people do it every year, but I think we're all feeling our way and there is certainly no data. They're trying to put that together right now. I don't remember which of the trials is looking specifically at that. There is one looking specifically at that. I think we're just kind of guessing as far as how often to do this. Somebody orders CCTA baseline on many patients. It's very costly. My understanding is it's not diagnosis of chest pain. It doesn't have to specifically be pain. It can be symptoms consistent with angina, which doesn't have to be pain. And then the rest of it about what happens to their insurance after they get that diagnosis. I don't know how to respond to that one. If you scan 100 people, especially 100 men over 40, with this test, you're going to find over half of them are going to have plaque.
Yeah. I mean,
It's, it's just the prevalence of the disease.
on this point about life insurance and disability, I have personal experience with this. If you do anything through the formal medical system, meaning insurance or retail pharmacies, I ran into an issue where I was prescribed metformin for longevity purposes. And then when I was applying for more disability insurance, they saw this and they just triggered this whole thing. And they ended up, I have a rider now where like they think I have diabetes. This is what happens. And so I do think this is actually another argument to go through. If you go cash pay, that is not visible to the system. The same is true for compounding pharmacies. If you get something through a compounding pharmacy, it will not hit Sure Scripts, which is the thing that, I mean, it's amazing how difficult it is for us to get records. Life insurance companies, they get everything. They were asking me about stuff that happened in college. I didn't even know where they got those records. So just something to think about. It is relevant for what we do here because we do a lot of preventative stuff. We do a lot of prescribing off label. And just know that if you use retail pharmacies, that stuff will show up if
Mm,
somebody applies for life insurance or disability insurance, and there can be consequences of that because that industry is not caught up to all of this.
yeah. I think that's a really good call out. And I don't have a recommendation for you other than what Anand said, I think is right. As far as which AI package, we have not decided. I think they're all pretty good. And to be honest with you, a big part of it for us is going to end up being cost. They're all pretty expensive. And because they're very close in performance, I think cost will be a big driver. Is the CCTA more useful than ordering a stress test? It is more useful if what you're trying to do is use it to manage medical therapy to prevent an MI. If what you're trying to do is evaluate whether a flow limitation is causing a patient's symptoms, then no, a stress test is probably a better test to do. But if you're using it to try to manage somebody from the perspective of, like, I want to know how aggressive I need to be with my lipid lowering therapy, metabolic disease therapy, visceral fat, etc., no, then the CCTA is tracking the disease that you actually care about. And then the last person here has got something about like that somebody recommended against these tests, but you did it anyways. Good. Calcium, the CAC was normal, no calcium, as we talked about. That's good, but doesn't guarantee that you don't have plaque there. I don't know if you've got zero plaque, and I don't know that you've gotten a CTA yet or not. I just saw that you got the CAC. But if there's no plaque present, I don't know that adding the different types of particles is very helpful because you're doing pretty well. That's the score of the game. If the score is good, I'm not sure that trying to break down the particles you have is really going to help you a whole lot more in terms of guiding what therapy to do. I tried to go quickly so that I would have plenty of time here. Hopefully that was okay for you.
Oh, that was great. And I think, just to kind of emphasize a point that you mentioned earlier, and I think this applies to a lot of tests that we do in longevity, especially things like full body imaging. We spoke about this in our meeting
Mhm.
before, but like everything from full body MRIs to in-depth neurocognitive scans, or rather brain MRIs, to even liquid biopsy and things like that. And I think all those things have merits and there's a debate worth having. But to me, cardiovascular screening stands in an entirely different category because the solution set is so robust. And again, this idea of triggering an unnecessary cascade, like I agree with that. It's actually a completely, it's like it's non-existent, right? Because there is
Yeah.
no rabbit hole because we have a bunch of tools to deal with what we find, and
Mhm.
they're all appropriate. They've all been extremely well studied. They're extremely well tolerated. We're not talking about using stuff that's not FDA approved. It's extremely robust. I think there are people now advocating that we should get to a point where people do not die of cardiovascular disease. Like at some point, in the
Yeah.
next 50, 75 years, like we get to that point. And I think when we use other tools, we have to think about like how good is the tool set. And my hope, and I think all of us believe that we will get there with cancer and other or therapeutics. Right now, we're just behind where we are with
I,
cardiovascular.
I couldn't agree more. I do think if it takes 50 or 75 years, it's only because it would take that long for a mindset shift within the healthcare community or because of reimbursement reasons, not because the technology doesn't exist. The technology exists today. The diagnostic technology is robust and exists today. We have exactly what we need. The photon counting machines are going to be even more accurate and lower radiation. That's a new generation of CT scanners becoming available now. That will be even better, but the ones we have today are good enough. When we're treating somebody, if we have access to all the therapies that I put up on those screens, all the lipid lowering therapies, all the metabolic disease and weight loss therapies that we have, if we can use all those drugs, we're going to be able to, like, there's very few patients that are going to get past us and still make plaque after we've used all those therapies. Plus, I'm sure like exercise and diet coaching as well on top of that. Just very few people that are going to break through all that. I won't say zero, but very few. And going from the number one cause of death in the Western world to very few patients would be just, in my mind, just heroic. I mean, it would just be a huge impact on people everywhere. And not just on death rates, but this is a big cause of disability as well. You have all these issues with heart failure and other things too that come along the way that just really, really bad.
So we just have a few more minutes left here. If anyone has any final questions, please feel free to drop them in the chat. Anthony, this was a really great summary of the tool set we have to screen for cardiovascular disease and how I think in many respects, this has a potential, if properly adopted, to actually simplify how we think about cardiovascular disease. It's become quite complicated now with all the different calculators and considerations of risk
Yeah.
pools. In a lot of ways, this is simplifying to me, where it's just like, okay, this gives you kind of like almost like a binary or somewhat deterministic output. This is how much plaque you've built up. And
Yeah, it
very
reminds me, just a week or two ago, I was flying home. It was late at night, and I was on an airplane and watched a movie that I had seen before just because I was sleepy and wanted to do something comfortable. I watched The Big Short. It's about the whole bursting of the real estate bubble. And as I introduced that movie, a few people did what nobody else did. They looked.
yeah.
And that's really what this is all about. Like, we just have to look. We're not looking right now. We've got the tools to be able to do that. We're really endeavoring to just make it, that become the standard of care. I think it would save a lot of lives. So
Awesome. Well said. I love that movie too. I feel like that must be one of the best movies.
it
Very
was great.
plain.
I just, it was the end of the day, long business trip, and I just wanted, a glass of wine and to sit back and relax.
Yeah, yeah.
So
Awesome. I think that's a great way to close out. Thanks all for listening. The recording will be up shortly. Anthony, thank you so much for speaking with us, and I hope everyone has a great weekend.
thanks everybody for joining. Bye bye now.
Bye bye.